classification and prevention and control of the same. Okay. Introduction. What we write in the introduction: protein energy malnutrition is a deficiency disease caused in infants due to what? Due to food gap. Okay. Between intake and the requirement. It is just the supply and the demand. If the supply is less and the demand is more, again, there is a gap. Okay. Again, protein energy malnutrition. Nowadays, you can, what you say, obesity also can be described as malnutrition, where the demand is less, supply is more. Whom does the protein energy malnutrition affect? The children who are under 5 years and who are from poor underprivileged communities. Is it serious? Yes, it is serious. When does it occur? During the post-weaning stage and associated with infection. Okay. It is a wide spectrum of clinical stages. We'll be looking at this. Severe forms like kwashiorkor and marasmus to milder forms, in which main detectable manifestation is growth retardation. Okay. How do we classify the protein energy malnutrition? We'll look at it. There are so many ways to say that protein energy malnutrition is there. First, we see undernutrition. If you want to say the child is underweight, you have to compare this weight with something to say it is underweight. Underweight for what? For height, age, or society, or the similar age group of children. Comparison of weight for that age where the normal child should have at that age. That is called as underweight. Okay. Stunted, again, it is a comparison. Height for that particular age. Wasted means the muscles are dangerously thin. That means the muscles are not built up according to the requirement. The other one is micronutrient malnutrition, deficiency of vitamins and minerals. It is called as hidden hunger. Okay. We look at the epidemiology. Epidemiology, the diet, which is deficit in protein and energy or calories, results in PEM. Okay. When does it happen? After 6 months, the demand of the baby increases from not just the breast milk, it needs extra food also, extra energy or extra proteins and vitamins, carbohydrates, everything. If the baby is prolongedly breastfed and nothing else, and that breast milk secreted is poor, then the child will end up in PEM. The other causes is poverty, socioeconomic factors, poverty, which leads to low food availability or unsanitary living where the repeated infections do happen. We will look at the infection cycle later. Improper distribution of food among the family members. What happens in Indian families is the elder most will have the food and the youngest most will wait for the food. By the time it reaches the youngest, the food would have been got over. Okay. Improper childcare and neglect. First child is male or first child is female. Second child is also female. Third child is male. And the first child is 1 year. Second child is first child is 2 years age group. Second child is 1 year age group. This is 1 month age group. The male kid gets importance. The other two childs are neglected. After 6 months, only certain foods are given, and usually the rice or ragi is given. Other vegetables are not given. Okay, that again leads to micronutrient malnutrition. Environmental factors, again, overcrowding in India and sanitary living conditions will lead to it. Respiratory infection is a diarrhea, repeatedly getting infected. We'll look at the cycle. Biological factors like poor maternal nutrition during pregnancy and during adolescent age, infectious diseases causing more than during the pregnancy and during the childhood and infancy, and lack of adequate nutrition further reduces the further increases the risk of PEM. Okay, and nowadays we don't have practice of feeding fruits to our children, so there is lack of free radicals and alpha toxins. Free oxygen radicals and potential are toxic cell membranes produced in body during infections. How do they get neutralized? By antioxidants. Where do we get the antioxidants? From fruits and fresh fruits and other vitamins. So these free radicals are not combated well within the child's diet. Okay, when they are deficient in A, C, and E. Again, this will lead to infection and protein energy malnutrition again. Age of the host, more common in the first 5 years of child, and especially first 3 years is very crucial. PM in pregnant women and lactating women can affect the growth of the baby. Elderly people do suffer, but not to the extent how much does the child suffers. Okay, this is the cycle of malnutrition and infection. There is inadequate dietary intake, which will lead to weight loss, growth failure, low immunity, and mucosal damage, which leads to infection. This infection leads to decreased appetite, decreased nutrition, malabsorption, all and metabolism. Again, there is because of this, there is decreased intake of food. This is the cycle which keeps on running. Please do not forget this cycle, which is very important. Okay. Next, we have classification of PM. It is a spectrum of conditions ranging from growth failure to overt marasmus or kwashiorkor. Kwashiorkor and marasmus are the two extremes. Other various classifications are Gomez classification, IAP classification, WHO classification, Waterloo, and Welcomes. If you can't remember all these, at least please remember the names if you can't remember the classifications. Gomez classification, it is based on weight for age. Okay, in this system, the normal reference of the child is 50th centile of Boston Standard. How is it calculated? The numerator is weight of the child by the weight of the normal child of the same age into 100. Okay, if it comes more than 90%, it is normal. 75 to 90, grade 1. 60 to 75, grade 2. Less than 60%, it is grade 3. This is Gomez classification. Coming to the what are the uses of it? There are disadvantages are the cutoff is very high. One is 90% and 80% is equivalent. That is 2SD or third percentile. Okay, and if you classify the Indians in this standard, you can say all are in at least in grade 2 or grade 3. This is the standard. Okay, the standards of Gomez classifications are comparatively higher. Coming to the IAP classification, the formula is the same, but if the normal, if it is more than 80%, it is considered to be normal, whereas in Gomez, it is more than 90%. Okay, grade 1, 70 to 80, grade 2, 60 to 70, and we have grade 4 also. There was only grade 3 here, whereas we have grade 4 also in IAP classification. WHO classification has two, that is moderate nutrition and severe malnutrition. Weight below 2 standard deviations is moderate. Weight below 3 standard deviation, it is severe malnutrition. Waterloo's classification, again, it is height for age and weight for height. Okay, it compares both weight, height for age and weight for height. It gets stunting also, it gets wasting also. If this, it can be plotted in the 2 into 2 table. This is normal. If only weight for height is affected, then it is wasted. If height for age is affected and weight for height is normal, then we call it as stunted. That is, height is reduced, not to the appropriate level. If both weight for height and height for age both are less, then it is called wasted and stunted. Okay. Wellcome's classification, we have parameters, that is weight for age and edema. Reference is again 50th percentile. There are four grades, 80 to 60%. Without edema, 80 to 60%. Edema is kwashiorkor. Less than 60% with edema is marasmus kwashiorkor. Less than 60% without edema is marasmus. That means the weight is in say 80 to 60%. But there is edema. That means it is underweight. Here the weight is little bit reduced. There is no edema, so it is underweight. Here the weight is in the range of 80 to 60%, but there is pitting edema. This is kwashiorkor. This is marasmus kwashiorkor, and this is marasmus. This is what you have to remember. Wellcome's classification. Again, we have midterm circumference also, which is midterm circumference more than 35%. It is normal. 12.5 to 35, that is intermediate, or you can say inconclusive. And mid-arm circumference 12.5%, we have call it as severe malnutrition. Marasmus is we'll see what is marasmus and kwashiorkor. Okay, first we'll see what is marasmus. Marasmus is a form of PM where growth is severely retarded and usually occurs in first 2 years of life. That means marasmus comes early. What are the symptoms? Very less subcutaneous fat. If you hold it, there is no fat at all. Okay. However, there is no edema. Press it on the any bony prominence, usually on the dorsal aspect of the foot or the medial malleolus, there is no edema. The height of the child seems larger than the body and has very little air on the head. The child is below 60% of her or his weight for that particular age group, and the height of the baby is also affected. The skin has some pigmentation or peeling skin lesions. You can see the skin lesions coming out of forearm or on the legs. You can see the ribs, and because of the absence of the tissue under the skin, the rib cage is prominent. Okay, like rickety rosary, which appears in calcium deficiency. These are the symptoms of marasmus, and the abdomen appears to be extended or protruded. If you imagine this is the child standing, the chest is like this, whereas abdomen looks like this. Okay, this is the head. Due to weakness in abdominal walls and wasting, more prone for infections, and child is very irritable and whines a lot. Whines types. Okay, child loses interest in environment and inactive with the other kids. The fat on the face is last to go, so post which the child gives appearance of old man. Hence it is called as old thin man, or you can call it small thin man or old thin man. Body has shriveled body, wrinkled skin, and bony prominences. You might see anemia sometimes to moderate degree and other micronutrient deficiencies. The appetite of the child is lower compared to the other children. Okay, you can see the child is very thin. Now we have kwashiorkor, which is uncommon in the children less than 1 year age group. Remember, the marasmus is common till 2 years age group. Kwashiorkor, you can commonly say more than 1.5 to 2 years after. Okay, what are the symptoms? 3 essential features: growth failure, edema, and mental changes. Okay, the weight of the child depends on the extent of the edema in the body, but the weight of the child is usually less than 60% of the expected weight. The child looks very chubby, but the weight is less. The height of the child is affected more, and retardation is more pronounced than marasmus. Okay. Pitting edema appears on the feet, legs, and later spreads to the whole body. The face looks puffy, like chubby cheeks. Okay, and swollen highlights. These are the symptoms of kwashiorkor. Abdomen distended, but ascites is not seen. Abdomen is distended there also, but you are comparing the abdomen there with the chest. Chest is too small in marasmus. The liver is enlarged due to fatty infiltration, and the symptoms include laziness, moon face because of the chubby face, and loss of hair results in patchy alopecia. And skin changes, you can see pigmentation and depigmented patches, peeling leading to crazy payment of dermatosis. It is very, you can see them, but very rare. Anorexia is common. Diarrhea may occur due to defective digestion and absorption. Again, they are associated with iron folic acid, which is leading to anemia. Anemia is seen to up to moderate extent in marasmus also. Okay. Now we have seen the two extremes. Okay. Just a minute. It is time to stop the first poll. I'll be starting the second one now. We have seen the two extremes, that is marasmus and as well as kwashiorkor. Now we have mixture of both. This is also malnutrition. It is the midway. Okay. Child who does not have anemia first, which will develop later. Okay. This is due to lack of energy only. There is a various degrees of muscle wasting compared to the upper limbs and lower limbs. Edema is seen and skin changes are also seen in marasmic kwashiorkor. There is a presence of moderate anemia along with other vitamin deficiencies. Vitamin A deficiency is associated with severe malnutrition and may cause blindness. Okay. How do you write this in an answer? First, you write marasmus. Second, start off with the kwashiorkor. When you write the symptoms of marasmic kwashiorkor, you do mention all the symptoms. Okay. And please do remember anemia is seen in all of them. Okay. Don't think that I have mentioned there also, here also. So why should I mention here? Please don't use that logic, because you are writing an answer. You are not teaching someone. So when you are writing an exams, please do mention all the symptoms and all the headings. Don't go with the pretext that examiner can assume that I have already written there. Okay. Complications, again, it will cause water imbalance and electrolyte imbalance in the body, hypothermia, low temperature, hypoglycemia, low blood sugars, superadded infections, multiple bacterial and viral infections, vitamin deficiencies, lactose intolerance again causes diarrhea, cardiac failure because of overload of fluids in kwashiorkor, bleeding tendencies because of deficiency of micronutrients, example vitamin K, renal impairment, and in long term we can have growth retardation and as well as mental retardation. How do we prevent and control protein energy malnutrition? There are four ways: health promotion, specific protection, early diagnosis, treatment, and rehabilitation. Please do remember all the four steps to be written in exam. Health promotion. How do we promote the health? You need to give something to promote it. What do you give? Either you give food or you give the education to take the food. Only two aspects are there: education and supplements. Nutritional education through what? ICDS program. Who is giving? ANM or Anganwadi worker is giving. To whom? To women. Which women? Adolescents, pregnant women, lactating mothers. Okay, all of them are getting the education as well as micronutrient supplements. Under which program? Micronutrient supplements under Pradhan Mantri Matru Vandana Yojana. They receive cash intensive that they can be used to purchase all these things. Okay. Cash incentive is also given as a compensation to loss of wages also. Promote breastfeeding, again under ICD's program. And there are additional programs like Shishu Suraksha Karyakram, which supports breastfeeding mothers in public health institutions. Development of low cost feeding foods, that is through ICDS. For what? For weaning at the right time with the right nutrition. Okay. Next is family planning. Why family planning is important? For spacing and planning of pregnancy. Okay. Which programs? Janani Suraksha Yojana and Pradhan Mantri Surakshit Matritva Abhiyan Yojana. They offer family counseling services and help them in spacing pregnancies, which is both help beneficiary for maternal and child health. Health home economics through ICDS program. Women receive education on home economics, how is the budgeting done at home, meal planning, food preservation, and improve the food security and family environment. Okay, which can be more supportive for maternal and child health. Coming to the specific protection, protein energy rich food. What are those protein energy rich foods? Milk, eggs, fruits are essential. Okay. Poshan Abhiyan program focus on improving the nutritional status of child, pregnant, and lactating mothers by encouraging to intake of diverse nutritious foods. And supplementary nutrition is provided through ICDS program for whom pregnant lactating women and childless 0 to 6 years. We have already finished this class in last session. And specific protection from whom? From infections. By what? By vaccination that is given under universal immunization program. You have enough time, please do write the vaccines provided under this program and the timelines, that is schedules. And Mission Indradhanush, 7 infections which are covered through vaccinations. Okay. Rainbow, again, 7 infections. Please do list out the names as per the program. If you have time, if you don't have time, please do mention the Universal Immunization Program and Mission Indradhanush. Specific for protection by food fortification, that is by giving fortified food which is containing of the essential nutrients. Sometimes the rice was fortified with vitamin A. Okay. There is a fortified rice which is distributed through public distribution system and midday meal scheme. I'll check out whether it is still running or not, the fortified foods. Early diagnosis and treatment. How will you do the early diagnosis? By history taking meticulously and screening for the clinical features, anthropometry, both height, weight, mid-arm circumference, chest circumference, head circumference. All these things will give you the clue whether the child is going into protein energy malnutrition or not. Biochemical and lab investigations, again, iron, for iron deficiency anemia, HB, MCV, MCHC, peripheral blood smears, okay, and iron studies, and proper and effective management of infections. How do we rehabilitate? By hospital treatment and referring them to the nutritional rehabilitation centers which are developed or which are being established at the village level or the PHC level. And the most important, which everyone neglects, is follow-up care, which is very much important in today's scenario. Coming to the next questions, that is short answer. Okay, we'll see whether what is the poll timing. It is still 8 minutes. Okay. The first short answer for today is iron deficiency anemia, which is also nutritional anemia and its prevention, anemia prophylaxis program. Okay. Please do remember this question can be asked as a main question or a long essay or a short essay or a short answer. It can come anywhere. And this can be asked in your gynecology, it can be asked in pediatrics, it can be asked in your general medicine also. Okay. India is the probably the highest prevalence of nutritional anemia in women and children. This is the fact. About half of the pregnant women and children are suffering from anemia, and 19% of the maternal deaths are because of anemia. According to NFHS 5, 52% are anemic, of which 45% are in urban areas and 54% are in rural areas. Hardly 10% difference between urban and rural. So the condition is same as urban and rural. Okay. What is the consequence of iron deficiency anemia? Either there is decreased intake or there is increased requirement. Demand is more or supply is less. Okay. Apart from that, there's a third part in this, that whichever the stores in your body are getting lost. Okay. It is similar to your bank account. You are putting more money into your bank account, or you are withdrawing more money from your bank account. Okay. What is the third part where you lose the money? Bank itself is losing it somewhere by giving loans. This is as simple as iron deficiency anemia. In children, what are the most common causes? Low iron stores, because due to anemia in the mother. Instead of exclusive breastfeeding, they would have started sugar syrup, uh, what we say, cow milk, buffalo milk, where the infections are happening. Okay. Too early introduction of complementary food, that is very late lesson iron, and late introduction of appropriate foods, that is late weaning. Breastfeeding till 1 year, not giving any supplementary foods or complementary foods. It is not supplementary, it is complementary foods, and giving only rice or milk in the complementary foods. Insufficient quantity of iron or iron enhancers in the diet, and low bioavailability of dietary iron. Okay. Low bioavailability means, that is, iron content is there in the food, but it is not getting absorbed. Okay. Increased iron requirements, it is as such is a requirement because of the growth of the child. And where there is a loss due to parasite overload, either it is malaria or intestinal worms. How does the intestinal worms happen? Again, sanitation comes into play. Okay, it is just the cycle. In mothers, insufficient intake, first one, and low bioavailability food, excessive quantity of iron inhibitors, consumption of tea, coffee, and calcium-rich foods. Soon after taking food, if you are consuming tea, coffee, or calcium-rich foods, it will reduces the iron absorption. Increased blood loss during menstruation, again causes anemia. Poor iron stores from childhood or infancy and adolescent. Iron loss during postpartum hemorrhage. Increased requirement due to tissue or blood energy or requirements during the pregnancy. Teenage pregnancy where there are no adequate stores. Repeated pregnancy within 24 months. Iron loss due to parasite, again infections. Poor and pure environmental and water sanitation. What are the cutoff points? Okay. When you say that individuals have anemia, if in adults, males less than 13, females less than 12 if they are pregnant, non-pregnant if they are pregnant, less than 11, child 6 months to 6 years, it is less than 11, 6 to 14 years, less than 12. Okay. How do we prevent? This is the whole cycle whom you have to prevent in anemia in. Okay. Then next we have the program, which is containing who gives what. In children, 6 months to 6 months, 60 months, that is 1 ml of iron folic acid syrup containing 20 milligrams of elemental iron and 100 micrograms of folic acid given twice a week. Okay, 10 to 19 years, 100 mg of elemental iron and 500 micrograms of folic acid once a week. Okay, in reproductive age group, 100 milligrams of iron and 500 milligrams of folic acid once a week. Same as adolescents and pregnant and lactating women. 100 milligrams of elemental iron and 500 of micrograms of folic acid daily for 100 days, followed by similar dose for 100 days in postpartum period after, that is after pregnancy. Okay, we'll see in anemia prophylaxis program who gives what. Up to 6 to 60 months, it is delivery by who? Asha worker, which is included in mother child protection card. Okay, 5 to 10 years, you do know the dosage now, either through school teachers or Anganwadi workers or mobilization by Asha. 10 to 19 years, that is adolescent age group, Anganwadi workers, school teachers, and mobilization by Asha. These are the service delivery personnel, which is very important. Pregnant and lactating women, ANM, ANC worker or Asha worker, again it will be endorsed in mother child protection card. Women in reproductive age group, Asha worker does the service delivery job here. Okay, this is the anemia prophylaxis program. Who gives what and to whom and when. Age group, what is given, when it is given, and by whom it is given. Who is it, what, when, and by whom. All these four components are included in anemia prophylaxis program. Okay. Coming to the spectrum of iodine deficiency disorders and its health hazards and their prevention. Before this, I'll stop the poll. It is already 15 minutes. All these are three markers, but we are discussing a little bit elaborately because it might be asked as a short answer also in the later stages. This is the spectrum of iodine deficiency disorders. Okay, from starting till ending. This is the severity. Low severity, high severity. Okay, first one is goiter, that is swelling in front of in the neck. Hypothyroidism, subnormal intelligence, delayed motor milestones, mental deficiency, hearing defects, speech defects, based on the uh, availability of iodine or thyroxine hormone. Strabismus, the child will not have binocular visions on birth, during birth. So this binocular vision is developed after the birth. So iodine is important for developing binocular vision. Nystagmus, spasticity in muscles, neuromuscular weakness, endemic cretinism is the severe stage. Okay. Goiter, again, the enlargement of thyroid gland, which causes breathing and swallowing difficulties. Hypothyroidism, reduced thyroid hormones, which can lead to fatigue, weight gain, cold intolerance, and depression. Cretinism, severe iodine deficiency during pregnancy leading to congenital hypothyroidism, stunted physical and mental growth in infants. Again, we have intellectual impairment, lower IQ, growth retardation, and increased pregnancy loss and infant mortality because of hypothyroidism. Okay. How do we prevent this? The only way is you give the iodine. By what? By adding to the food in the iodine. Sorry, iodine to the food, or you take the iodine rich food which is already having good iodine. For example, seaweed, fish, eggs, and dairy products and dietary supplements. Okay. Here you can see there is no vegetables at all. Okay. All these are animal products. So what did the government do? The government started supplementing supplementing iodine through some other form. That means which is consumed by all. For example, in the places where people are living in the hilly and mountain regions, they where do not have access to these kind of foods and vegetarians. How do they get iodine now? So the iodization of the salt was done. Okay. Initially, there was National Goiter Control Program. Okay, to address all these issues. In 1992, this program was renamed as National Iodine Deficiency Disorders Control Program to include all end-to-end and to implement in all states and territories, union territories. This was formed. This program was launched. What does this program give? Survey to assess the magnitude of iodine deficiency disorders in districts. Supply of iodized salt in place of common salt. Resurveys to assess iodine deficiency disorders after every 5 years in the same districts. Lab monitoring of iodized salt and health education and publicity of consuming iodized salt. At one point of time, there was in 1995 2000 iodized salt ads used to come in the TV, okay, which are actually less now. Achievements: the production and supply of iodized salt from April 2015 to August 2015, in the span of 5 months, it was 26.44 lakh tons and 25.12. This is the uh, capacity of the India's production. Okay, and we don't get common salt, which is not iodized now. And later, Food and Safety and Standards Act 2006 said that non-iodized salt should be banned. And nowadays in India, we don't get non-iodized salt. We get iodized salt. Okay. Next, we have neurolaterism causes, clinical features, interventions of for control of the problem. What is neurolaterism? It is a crippling disease of nervous system because of spastic paralysis of lower limbs. Okay, occurs mostly in adults because of consuming a particular pulse called Lathyrus sativus in large quantities. Not once in a 6 months I consume it and I get neurolatherism. No, it does not happen like that. Okay. Lathyrus sativus is commonly known as kesari dal. In local names, it is called chora dal, lak dal, or batra, garas, or matra dal. Okay. It is good source of protein, but it has a toxin which affects nerves. It is who consumes it? It is consumed by people who are not affordable for other type of pulses. Okay, this is relatively cheaper. So hence the laborers, agriculture workers, uh, migrant workers, they consume this. Okay, if the diet forms more than 30% of this protein and sorry of this pulse, and they have consumed it for more than 2 to 6 months, then they will get this neurolatherism. 3 points in causes. One is it is called kesari dal, good source of protein, but it has a toxin. Okay, consumed by agricultural labor workers or uh, poor socioeconomic status workers, people. And how much of diet? 30% of diet for 2 to 6 months. Okay, which is the toxin? Beta oxalyl aminoalanine. This is the toxin. It is a water soluble toxin. Okay, it must be consumed in large quantities over a period of 2 months or more to cross the blood brain barrier. In smaller quantities, it does not cross the blood brain barrier. If you are consuming it in the higher quantities, then it crosses the blood brain barrier to affect this toxin to affect on the nervous system. Affects mainly young men between the age of 15 to 45 age group. Why? because these are the people who are working and require more protein. Either of the age group, apart from this age group, either they are dependents or require less protein. Okay. There are multiple stages in neurolathyrism, almost five. First one is the latent stage. In this, the individual appears healthy. Okay. But when he's put on physical stress, his gaits become abnormal. Okay. This is called as latent stage. During this stage, if the protein consumption is pulled out or taken off from the diet, he will recover completely. He or she will recover from the disease completely. Okay. Second, we have no stick stage. There are short, jerky movements. A large number of patients will be found in this stage but not diagnosed. Okay. Then we have one stick stage, means the individual takes the support with a tendency to walk on toes. Okay. Why this happen? Because there is a muscular stiffness which is causing imbalance. And we have two stick stage. The symptoms are severe, and due to excessive bending of knees and crossed legs, the patient needs two crutches for support. Okay. Third is crawler stage. Finally, the erect posture becomes impossible as the knee joints cannot support the weight. Okay. There is atrophy of the muscles in the lower limb, and the patient is load bearing capacity comes down. Patient is reduced by crawling by throwing his weight on his hands. This is the last stage. What are the interventions we can do? You give something else, that is vitamin C prophylaxis, to reverse. There are studies which say that giving almost 1 gram of ascorbic acid for a week or so can be reversed. Okay. It was tested in guinea pigs and monkeys. Then you ban the crop, cultivation of that crop. Again, it will lead to less availability of the protein, which is practically not possible. Okay. And this is cultivated more in Madhya Pradesh, Bihar, Orissa, and Gujarat. The other one is you remove the toxin. Since the toxin is water soluble method, you soak the pulses in hot water for almost 2 hours, then remove the water, wash it, drain and dry it in the sun, then consume it. Drawback is other vitamins and minerals are also lost with the toxin. Parboiling method, it is what we say half boiling method, like simple soaking in lime water overnight and discard, which discarding the water again removes the toxin. And the other one is education, asking them not to consume in the large quantities. Third is genetic approach, like getting the pulses which are not having this toxin but having the same protein content. It can be availed from Indian Council of Agricultural Research from Delhi. Okay. Socioeconomic changes improve the economic status of the population. Again, they will not buy this pulses. We have last question for today, that is dietary surveys in India. What are the dietary assessment surveys available in India? Okay. First, we have 24-hour dietary recall. You ask the patient what all he has consumed since yesterday morning till night. Okay. This is the most common method which is used in India and used in National Family Health Survey also. It is very simple and effective. I can remember what I had yesterday morning. And if someone asks what I had day before yesterday morning, I can't remember. So it is called 24 dietary recall method. Limitations again relies on the memory, leads to underreporting or overreporting. If you ask someone, someone says how many idlis you had yesterday, practically you might have four. You might say I had eight if he's in a very good mood. Or if he's in a very bad mood, you might say no, I had only two. This is the one of the limitations. Food frequency questionnaire. You can take it for a week or so by asking how many times you consume fruits in a week. how many times you have non-veg in a week. This is based on the regional and national studies and the habitual intake. If I'm a non-vegetarian, how many times do I have a non-vegetarian in a week? Okay, this gives you long-term benefits, that is almost a week or a month. But as how many times you have consumed mutton in last 1 month? People might say twice. It is normal to have once in 15 days or once in a week. So they might say 4 times or 2 times every month. It gives you a long-term effect. Limitation again, uh, remembrance may not capture all the food consumed and relies on ability to estimate frequency and portion sizes. I visited a wedding last week, so I had very good food. So if I visit 4 weddings in a month or 2 other parties, again the frequency gets disturbed. Food diary, writing down all the foods which I have consumed, uh, like maintain a book. Okay, limitations can be burdensome for participants. Asking them to write down whatever they have and wait and use it, again, it will be a difficult one. Household consumption expenditure. Uh, you ask the individual how many kgs of tur dal you consumed last month. The lady may say 1 kg. Okay, and there are 4 adults, 2 children. So there are 6 members in the family. 1 kg divided by 6. This is the per person consumption. This is used in National Sample Survey Office records. Provides comprehensive data, but it is not accurately because the consumption by these two are totally different from consumption by these four. Okay. Diet history interview. This is a structured interview used in clinical settings where they can remember, or there is a diet chart available. It is very time consuming and relies on participant memory again. Okay. What we can do for overcoming all this? Use mobile apps or digital tools. Okay. Uh, have an app with, for example, say Monday. Today is Wednesday. Sorry, Tuesday. Say I have breakfast, lunch, and dinner. Capture the photograph for all these threes every time, and the photograph to assess using AI the how much grams of uh, fruits are there, how much grams of carbohydrates are there, how much grams of proteins are there, how much grams of vegetables are there. All these things. The other one is giving blood samples, which is very difficult. Okay, because giving blood samples every day for the sake of monitoring of food intake and monitoring the biomarkers, it is doesn't look practical. No one will turn up for the lab for giving blood samples every day. With this, we'll be completing the first class of nutrition. Thanks for watching. And we do have a social media handles, that is on YouTube, Instagram, Facebook, and Telegram. And we have app for Android users as well as iOS users. Thanks for watching. Happy Diwali again. Thank you.